folks, we're about ready to begin. We'll start with the grand round. We have our own Dr. Paul Perry to talk to us about adult ECMO. But before I do that, I want to use one other congratulations here. Paul just got the University of California Davis approved by UNOS to be in a certified heart transplant program, which is a huge accomplishment. Just chatting a little bit about his background. He was a chief resident in cardiac surgery here in 15, 16 maybe, Paul, was it?
Yeah, 15.
And then went to Cedars-Sinai to get a 2-year fellowship in both ECMO, extracorporeal life support, as well as transplant cardiac surgery. And both of those he has brought back here to UC Davis and developed, I think, masterfully. So it's a real accomplishment. He is a slug by undergraduate training, right? You're Santa Cruz slug?
Yeah, UC Santa Cruz.
UC Santa, aren't they the banana slugs?
Yeah.
Yeah, banana slugs. So he's a banana slug by training. And had a brief foray in the southeastern United States to see what Spartanburg, South Carolina was like. But since his family's from California, the difference between the eastern seaboard and the west is pretty clear. And came back here, and we're happy he did. So Paul, thanks for this discussion on adult ECMO.
Thanks for the introduction. So yeah, good morning. Can everybody hear me okay? Mic right? So yeah, I'd like to spend the time here kind of talking about extracorporeal life support, or probably better known as ECMO, actually the same thing. I'll talk about that. And really just to kind of use this as a way to bring everybody up to date on kind of what's going on with the field, especially as it relates to adults, because really a lot of the pioneering work, as we'll talk about, and a lot of the experience up until recently has been more in the pediatric realm. But as time has gone on, there's been more and more of a push into adults, and that's where I have most of my interaction with it. So I thought I'd kind of help talk about kind of where the field is and demystify some things about it, and really use it as an opportunity to kind of, you know, bring everybody up to date on what's going on with it, what's it good for, what's it not so good for, and kind of what's the directions we're going in with it. Here's my disclosure. So my objectives here are to briefly kind of go over the evolution of ECLS and ECMO, just kind of how we got to where we are with it. I want to talk some about respiratory failure, because that's probably one of the most important uses of it right now. Related to that, pulmonary embolism, kind of provide the group on where we stand with ECLS and the trauma population, and then talk a little bit about cardiogenic shock, which is mostly my wheelhouse. So I found this line. There's a pretty nice book chapter in this text, Extracorporeal Life Support for Adults, kind of talking about the history of ECMO. And I really like this line because I think it really summarizes a lot about ECMO. And that, in general, it should be considered if the disease or trauma meets the following criteria. It has to be severe, acute, and potentially reversible. And I think if you keep those three things in mind, that answers a lot of questions. Because a lot of ECMO is patient criteria, patient selection. And those three things really stand out. So just a little bit of terminology. I don't know if anybody else here has a warm feeling with the Stedman's Medical Dictionary, but that was like my best friend for the first few weeks of medical school. I didn't know what any of these words meant. But just some terms that we kind of throw around a lot to get everybody on the same page. So ECLS and ECMO are the same thing. ECMO is extracorporeal membranous oxygenation. That was the first term that was kind of used a lot. As it started to evolve as a field, and especially the work at Michigan, where a lot of this was kind of housed, as we'll talk about, they decided to kind of rename it ECLS because it was a more comprehensive term. But they're the same thing. But I think ECLS is probably a little more appropriate term to use for ECMO because the technologies can change. MCS is mechanical circulatory support. That's kind of my subspecialty here, I would say, in a lot of ways. So MCS. And that can be anything, and we'll talk about it, but ECMO is one form of it. Even a balloon pump is a type of MCS. Anything that's mechanical, it's helping move blood or oxygen around. And then we have VADs, ventricular assist devices. A lot of times when people think of VAD, they think of, you know, a durable HeartMate 2 that we implant. But really, again, anything that's supporting a ventricle, anything from a balloon pump to ECMO or HeartMate 2 is a ventricular assist device. And then when we're talking about types of ECLS or ECMO, there's veno-arterial, veno-venous, and veno-venous, veno-arterial, mouthful. I'll show what each of those are. So the fundamental objective of ECMO is to provide circulatory and or pulmonary support for somebody who has heart and or lung dysfunction. And so these are some of kind of the basic setups with it. But on VA ECMO, essentially you have a return coming from the venous side and an outflow going somewhere on the arterial side. So you're completely bypassing the heart and lungs, similar to a cardiopulmonary bypass machine that we use in cardiac surgery on a daily basis. And in that way, you're really able to rest both those organs simultaneously. This is different than VV ECMO, where your inflow is coming from the venous side and the outflow is also going on the venous side. So the idea is that you're oxygenating the blood before it sees the heart and lungs. The lungs don't really have to do anything at that point, and then it goes through the cardiac circuit and gets pumped out on the patient's own, with the own cardiac output, so the heart has to be working well. So you can have situations, we won't delve into it, but there are situations where you need VA, VV. So what that usually is somebody who's on VA ECMO, so the heart and lungs are essentially supposed to be bypassed, but the lungs are down as well, and some of the blood is escaping through the circuit, so you're not able to capture all the blood that needs to be captured before it gets to the heart, and some of it's still going through the cardiopulmonary circuit, and so then you're sending deoxygenated blood forward. And there are circumstances like that. And then in that case, sometimes you have to pre-oxygenate the blood before some of it escapes into the heart. So there can be VVVA setups, and that's where it gets a little more complicated, and fortunately it doesn't come up too often, but that is something that sometimes you have to do. So when we're talking about mechanical circulatory support, again, that can mean a lot of different things, but this is probably the best synopsis of it. You have ventricular assist devices, either left-sided only, as shown by here with a tandem heart setup, an RVAD only. You can have bivads. This is a centromag, that's extracorporeal devices actually sticking out of the chest, or probably VV ECMO, where you're actually not providing mechanical support for the heart, circulatory support. So really, any type of MCS is going to provide either, most of the time, some sort of ventricular assist device, whatever it is, and then the one exception to that would just be VV ECMO, where you're just doing pulmonary support. So this is kind of a brief timeline, but I think it's important to kind of know how we got to where we are and how things have come to be the way they are, because it's still impacting the field even now, and the investigations and the enthusiasm and just kind of how we got to be where we are. So in the first heart-lung machine that actually worked well was and used for a case described as the Gibbon IBM machine, heart-lung perfusion machine, and that was able to perform the first open heart surgery with an ASD repair that was done at Jefferson Hospital in Philadelphia, and that kind of started the whole realm of cardiopulmonary bypass. Unfortunately, Dr. Gibbon, he had that early success, but then the next several cases didn't go so well, and he kind of lost his enthusiasm for doing the cases himself, but he opened up the field for really everything we do now in cardiac surgery. Another really big pioneer was Walton Lillehei, who was at the University of Minnesota. This is, if anybody is interested in learning more about this history, this is an excellent book called King of Hearts that really just describes all the stuff that was going on during this time period. I read it right before I started my cardiothoracic surgery residency, and it really has just been a nice reference to keep in mind. But Lillehei, his way of doing the operations early on was actually cross-table circulation, so you'd hook up a child to the parent, and the parent was basically the cardiopulmonary bypass machine. They would have tubing going between the femoral vessels, and that way you could oxygenate the child from the parent. So that was pretty amazing and pretty great, and he had some good results with it, but obviously that's going to be limited. Dr. Kirkland at the Mayo Clinic really opened up the use of the cardiopulmonary bypass machine in the mid-50s. He kind of used Gibbon's machine and modified it and got it better and could do the operations a little bit better, and really had kind of a lot of the major early successes. And then, people started kind of exploring more and more ways to use the machines. Rashkin at CHOP in Philadelphia, this was the first time a neonate was supported with basically an ECMO type circuit, but it wasn't ECMO because it had a bubble oxygenator. So rather than membranous oxygenation, it was a bubble oxygenator, which is how a lot of the early pumps were used. And that child didn't survive, but it was the first attempt at using a machine for neonatal respiratory failure with a support. And then the membrane oxygenators came along. Dorson used one for a cardiopulmonary bypass run in a patient undergoing congenital surgery. And then one of the big successes was and the membrane oxygenator had a lot of advantages over bubble oxygenators, and over time replaced them. But in 71, Dr. Hill and his group from CPMC actually picked up a 24-year-old who'd had a motorcycle collision in Santa Barbara, orthopedic injuries, blunt aortic injury that was repaired, and then several days later developed severe ARDS. and was dying. They sent their team down there, picked him up, put him on this ECMO circuit, and sort of survived it. So this was like the first use of really supporting ARDS with a actually mobile ECMO as well, and had a survivor. So that was a big accomplishment. And then what really opened up the field, really for like probably the next 2 or 3 decades, was Dr. Bartlett's early successes. The first case was baby Esperanza. A lot of this was it actually started in Orange County. So it was a Mexican immigrant who came into the country, about to give birth, delivered at Orange County Memorial, and the baby wasn't doing well. And then Dr. Bartlett was in that area at the time at UC Irvine, and was able to use an ECMO machine to save the neonate. And that was the first successful case of that. And that was a huge accomplishment. Kind of opened up the field from there. That's the picture of the baby, and she's still alive now. There's pictures of him with her 40 years later. So again, there's kind of a couple early successes. So then started looking at the trial. There's actually an NIH funded trial, multi-center randomized control in the late 70s, and the survival is very poor. Less than 10% survival for both groups, ECMO versus conventional management. And this was really, as people have commented later, this was a sort of an example of doing a trial before the technology is really ready for that trial to be done. Just the things weren't sorted out well enough. The therapy probably wasn't really safe enough at the time. Kind of delved ahead with this trial, and then the results were disastrous. And that was really important because these sort of negative trials sort of influenced enthusiasm for the field to come. There was a lot of resistance to do things because of this trial and one that came a little bit later. But in the early 80s, Dr. Bartlett, by this point, had been recruited to Michigan, where it's really kind of been the home of ECLS therapy, kind of the hub since that time. Was able to describe a series of neonates that did pretty well with respiratory support, greater than 50% survival in a group that should have had less than 10% described. So that gave much more enthusiasm, again, in the younger population. And then as the membrane oxygenators were being used more than bubble oxygenators, that probably made circuits a little bit safer too, and bubble oxygenators have completely gone away. Smaller circuits, like the one by Bard, started to come out, so that would make things a little bit more mobile, a little bit more usable, a little more user-friendly. In the late 80s, ELSO was established. We'll talk about ELSO a little bit, but it's the Extracorporeal Life Support Organization. It's a big international organization that looks at this stuff, has a registry. We participate in it, pretty much all centers do. And that's been an important element of our field. And then there was another, that same year, there was another trial on neonates that had pretty good results. So again, more enthusiasm for the younger population. They did another randomized controlled trial for ARDS in adults in the early 90s, which again showed no difference. So again, this was sort of the things that didn't propel it as much on the adult side. But then there's been a couple more recent things that we'll delve into a bit more in this talk. The Caesar trial being an important one in 2009. And then what really probably kicked off a lot more enthusiasm for using ECMO, especially for ARDS, was the H1N1 epidemic that occurred in the late 2000s. Especially in Australia and New Zealand, two groups there were able to show excellent results treating ARDS from flu with the H1N1, and that actually kick-started a lot more enthusiasm for VV ECMO in adults. And then there's a more recent EOLEO trial, which we'll talk about. So it's just come a long way between that huge, massive machine to this. Is what we have here is the McKay CardioHelp system, which our hospital just purchased several of these. It's a really nice, cute little thing you can take pretty much anywhere. So this is a nice graph. I'm sure it's hard to read the numbers, but what this is showing is the number of centers doing ECLS and the volume of cases that's been done since the early 90s, and starting in 1990 to 2018. So what you can see is that the cases really, even in 6 years, have doubled from about 5,000 runs of ECLS to 11,000 in 2017 and 10,500 in 2018. And the number of centers has obviously gone up as well too. So as people say, the world's kind of going ECMO crazy. I mean, we're doing a lot more ECMO internationally. And this is by the Extracorporeal Life Support Organization, monitors all centers, pretty much all centers worldwide. So a lot more ECMO happening than there used to be. This has even gone to the point where in Paris now, there's a EMS team, the abbreviation SAMU, S-A-M-U. I don't know what it exactly means in French, but they kind of screen pretty much all the EMS calls that come through in Paris. And if they get the sense that somebody is in cardiac arrest or about to be in cardiac arrest from a PE or an MI or intoxication, they'll actually send out a team with a ER doctor versus an anesthesiologist, a nurse, and a paramedic to do field cannulation. So this is like the ultimate extracorporeal CPR, eCPR that people talk about. So if you're in the Louvre checking out the Mona Lisa and you collapse and you're young and they think you had an MI or whatever, the first thing they're going to do is try normal ACLS, but then somebody's going to be ready to cannulate you in the field and then take you to the hospital and sort it out. So that's, when people talk about the world going ECMO crazy, this is kind of an extreme example of it. It's pretty neat. Kind of on the flip side of that, this is one of my mentors, one of my MCS mentors, Francisco Arabia at Cedars, who said this once to me, and it really sunk in, was that if we put everyone on, soon we won't be putting anyone on. And this is an important thing because ECMO, while it can be amazing and you get big saves and it's great when it works out, it's resource intensive, it takes a lot of dollars, it takes a lot of work, and as we'll talk about, the outcomes, can be plus or minus. It kind of depends if you're a glass full or half empty type of person. So, at least in the US and in our environment there, we did have to be a bit cautious about who we put on ECMO. We get, consulted to be putting people on ECLS all the time. And you do have to use some discretion in doing that, because the point of this is that if you just start putting everybody on, you're probably going to have a lot of bad outcomes, and then probably the program is going to be looked at really closely and maybe even shut down. So this is a little, if you can read it, it kind of just shows the overall outcomes for adult ECLS, and it's pretty similar to neonates and pediatrics, which is shown above it, but probably a little bit better for kids all around. But essentially, just the numbers to kind of put in your mind, if you're doing VV ECLS, or it's for pulmonary support, about 60% survival all around. And that's been like that for a while. So even though we're doing a lot more ECLS, it's still about a 60% survival for VV. And for cardiogenic shock, for VA ECMO typically, it's only about 40% survival. That's all comers. Now there's a lot more that goes into that. We'll talk about that a little bit, but it's about 60% and 40%. And then the eCPR group, I'm actually surprised that this internationally they're saying 30% eCPR survival. There's a lot of interest in eCPR, I think, internationally right now and nationally, but it comes at a high toll, and these are very complicated programs. And I actually just saw a really nice review within the US showing their eCPR results, and it was only about a 15% survival, and even those people didn't actually live very long after they left the hospital. So I think 30% is excellent. It probably depends on how you call eCPR, but it is what it is. So how do we kind of determine who should get it and who shouldn't? Well, that's really the $10,000 question here, and nobody really has the answer to that just yet. And that's one of the actually exciting things about the field, is that it's still so evolutionary, and there's still so much going on, and there's still so many questions to be answered, that there's a lot of room for innovation. But if you go to ELSO, these are some of the tools they'll tell you to use to help decide, predicting mortality and risk and stuff like that. In adults, there's really just these two scoring systems. We're going to talk about both of them, the respiratory one, or at RESP and SAVE, one for VV and one for VA, essentially. And then all the rest are really mostly for kids. So there's not a ton of rules or resources out there to tell you exactly who should be put on and who shouldn't. And it's really important to keep in mind. So let's talk a little bit about ECLS and respiratory failure, usually the ARDS. So this is a chest x-ray of one of our patients from just this month, actually, 24-year-old female. This is a pretty typical thing for our service these days. 24-year-old female with asthma who is transferred from Lodi. She got flu from a family member, just normal, healthy 24-year-old who got flu and went to the ER and got extremely sick and extremely hypoxic. And then they're looking for help. And then they send him to us, and this is Dr. Rodriguez's patient. He put this Avalon VV ECMO cannula in basically on arrival on day 0 and got her stabilized. So internationally, greater than 13,000 people have been on ECLS for respiratory failure over the last 10 years, and the overall survival, like we talked about, is about 60%. Now, it's impossible to know how those people would have done without ECLS, right? You just can't, there's no way to know that, and some of the trials will go into it. But the idea is that if the survival had been less than 50%, that's statistically significant. So that 50% is an important number with respiratory failure. If you can kind of sift out who has a 50-50 chance of not making it, then and you can identify that group, they're 50% or worse chance of mortality, those are probably the people that are going to benefit the most from ECLS support for respiratory failure. Now, this would be sort of the ELSO indications for people when to put people on. And again, it's that 50% is an important thing. So if the P to F is less than 150 on 90% FiO2, or if they have this Murray score, which some of you may be familiar with, the Murray score is a predictor of poor outcome with respiratory failure. And about 2 is when you get a 50%, above 2 is a 50% mortality, then that's when you should consider it anyway. And then if you have higher Murray score than that, like 3 to 4, or a P to F of less than 100 on 90%, then it's probably indicated. And that's when you're talking about probably an 80% predicted risk of mortality. So this score is pretty easy to do. I mean, it's a little bit subjective, which is a problem with a lot of scoring systems, but you basically just look at all these parameters that you're dealing with, an average amount, and then you get a score. And then there's a couple other indications for VV ECMO, but the main thing for most people is going to be hypoxic respiratory failure. Sometimes you're going to have people with high CO2 retention, people with extreme air leak problems, things like that, but most of the time it's just going to be ARDS and hypoxia. Now, an important thing that you'll see over and over with ECMO, and a lot of MCS actually, is that there's no absolute contraindication to doing it. And this is really where the art and the experience and the data and all those things together, and the program and the institution and everything has to come together to kind of decide what are we okay with and what are we not okay with. But there's really no absolute contraindication of VV ECMO per ELSO anyway, and probably for a lot of people. But one thing that probably is discouraged, if they've been on high level mechanical support for greater than 7 days, they're probably not going to do well. So you have to identify it really as early as possible. Some of this stuff will show, but if you're over a week on, and just now if nothing's working and you're just trying to do a salvage thing, most of those people aren't going to do very well. So that's probably something that you want to bear in mind. And then of course if they have some other end stage process, right? End stage cancer, there's really nowhere they're going with this. It's just we're kind of prolonging things just to prolong things for a couple weeks. I think that's obvious to most people. So really the goals of early management is you just want to rest the lungs. That's what you're doing. You're just taking the lungs, taking all the work off of them for a while, and letting the circuit do all the load while the lungs get a chance to heal. And you want to have low FiO2 on your ventilator. You want to keep the plateau pressures low. And then like even an extreme of that, just an easy reminders, do 10, 10, 10, a rate of 10, pressure control of 10, and a PEEP of 10. Really just really low workload on the lungs, and you do that for the first at least 48 hours. If they're sick enough to need it and they really needed it, probably at least 48 hours, that's important. And then you're going to want to optimize volume and keep them sedated, and you can run into tricky situations where maybe they're hypermetabolic, and so even though you're running your circuit pretty fast and you have a good venous draw and you're putting 4 or 5 liters out, they're still hyperdynamic and they're putting a lot of deoxygenated blood across their heart. Then you might have to change your cannulation strategy, because even though you have good flow and your circuit's working well, they can still be pushing deoxygenated blood through the cardiopulmonary circuit. So you got to watch all that stuff really close. In that case, sometimes you have to work the lungs a little bit, but probably it's better to reconfigure your ECLS setup, or maybe slow the heart rate down with esmolol. Sometimes that works. Just do different things to try and keep them well oxygenated while minimizing the workload on the lungs. And then as you're once you get through the initial insult and the initial trouble, you almost always have to volume load them and just kind of stabilize things, let the dust settle. Then you really move into what, to me, is the most important thing, and probably the biggest difference between high-performing centers and lower-performing centers is goal-directed care. So what you want to say is, okay, this is where we are, this is where we need to be in 4 days, this is where we want to be in 24 hours, 48 hours, things like that. And then everybody has to just kind of work together to get to those goals. I think that's a really important thing, because you can make a circuit look good, right? There's line chatter, or pressures are up and down, give some volume, put on drips, do this and that. But sometimes those things work against the patient actually progressing. And that can be really challenging. And so I think that's why goal-directed therapy is just so important for this, especially with a wean, because you want to set your goal, and if you're not making it with the weaning parameters, you need to figure out why and what you can do to change that. Because if you just kind of spin them for days on end and don't get anywhere and don't get ahead, the outcomes typically aren't as good. So as they get through the initial insult and you're kind of watching things close, you're sort of at least daily, if not a couple times a day, assessing the lung compliance. So you just kind of challenge them and see what they can do, what kind of pressures you can generate, what kind of volumes you can generate, see if they're ready, see if they're not ready, get some more fluid off, whatever you have to do. And then once you feel like you're getting to a good point where the lungs are going to become more compliant, they'll usually show you. I mean, just all of a sudden you can see at the same settings you're getting much better lung volumes. Then you just start slowly weaning down the dial on the oxygen. and the sweep, which is the CO2 removal on the circuit. So it's a big difference between VA ECMO, where you're actually weaning the flow. On VA ECMO, you're weaning the flow so the heart can take back over the work. On VV ECMO, the flow stays the same. You're just weaning the oxygen support. So then at a certain point, the circuit's just spinning around room air, blood, and then you know you don't need it anymore. So in terms of trials, there's really not as much data as we'd like. There's those two early ones I mentioned that weren't good, and then there's two more modern ones. None of them have conclusive evidence. The one that's been the most cited and most talked about was the CSER trial, large multi-center, comparing ECMO to conventional management. This was based in the UK. Now, the endpoint here was death or disability at 6 months, and there was a statistically significant improvement. So 63% for the ECMO group versus 51% for conventional vent management. But the problem here was that the patients that got randomized to ECMO got transferred to an ECMO center, and then the other patients stayed under conventional management wherever they were getting. So what it was really comparing is patients that were being managed at an ECMO center versus a non-ECMO center. And the reason that was important was because 68 of the 90 people that got randomized to ECMO got ECMO, but 22 didn't. So over a quarter of the people that were supposed to get ECMO didn't actually get it. What they got was protective lung ventilation. So again, this is 2009. It was set up a little bit before that. Probably lung protective stuff wasn't as widespread or used as well, especially in maybe smaller hospitals. So when they sent them to a really high-performing ventilation hospital that had ECMO capability, those patients just did better. So it just showed that for people that are really sick like that, if they're in the hands of the best equipped providers, that's probably the better thing. And that's been a lot of the controversy on this. And that's why everybody just didn't go throwing everybody on ECMO right away, because it didn't really give the result we needed. And then the more recent one. So this is the EOLIA trial. And everybody was kind of waiting for this, especially with the CSER stuff being so controversial. And again, international perspective, ARDS in adults. Some of the criteria listed there, basically people are really hypoxic or a couple other circumstances. And then these people, importantly, none of them had cardiac arrest, and they'd all been on the ventilator for less than 7 days. So again, those are important prognostic things. But they went to immediately to VV-ECLS or to conventional therapy. And with this group, you know, there really wasn't a statistically significant difference. There was a trend towards better survival with ECLS. But part of the problem with this trial is that a lot of people in the conventional management group actually crossed over to ECMO. So even though they were just trying to do them with vent management, they were so hypoxic, and they had criteria for this. They were so hypoxic, so hypercarbic, so unstable, the pH was so bad, they just had to put them on ECMO because they didn't want them to just arrest. And so that was actually a pretty significant part of the group. And I mean, 28% of the people went to rescue ECLS. So it didn't really give the exact answer that we needed. So you didn't have a big difference. And then there was a lot of crossover. So again, the jury is still sort of out on the best people for this, but this is the best of what we have right now. But I think interestingly, there was quite a bit less stroke rate with the ECLS group. And that makes sense with VV ECMO because there tends to be less stroke in general, but they were better oxygenated, they had less ischemic stroke. So what can we use to help decide who goes on and who doesn't? Well, this is the tool that I mentioned earlier, the RESP score. And I think this is valuable because these patients are in extremis. You know, you're getting consulted, you're not sure if it's the right thing to do or not. You got to kind of make quick decisions, and you know, emotions get involved. Usually a lot of people put a lot of work into things, and it's nice to have at least some objective way to kind of get a sense of how they might do. So what this does is you basically just plug in a bunch of parameters, and it gives you a survival prediction. But what's important about it is I think one of the most important uses of this tool is kind of seeing which conditions work well and which don't. So things that are like reversible and you know turn around quick, like I talked about in that first quote, acute, severe, and reversible. So like pneumonia, viral infections, asthma, trauma patients that are generally expect the ARDS to calm down. Those patients they tend to do a little bit better. Whereas when you have end-stage processes like a central nervous system disorder or things like that, or you're kind of coming in real behind the eight ball, severely acidotic and stuff like that, you tend to not do as well. So you can kind of use these things to kind of help you decide who might be the type of person you want to give a shot with it. So just to kind of summarize our experience here over the last few years, this is for it's adults, but I really included anybody above age 14 because we ended up taking care of a lot of those in the adult unit, and a lot of them have adult type physiology. But over the last 6 years or so, we've had 42 runs and it's about 70% survival. This is with VV ECMO for ARDS. So we're doing pretty good with our program. The runs can really vary quite a bit in the length of them, as long as 47 days. And there's complications associated with them. Most commonly, probably infection that needs to be treated with antibiotics, and sometimes we have to do things with the circuits, but nothing really devastating with like a circuit stoppage or cannula falling out or anything like that. We do have to adjust the cannulas quite a bit, especially with that Avalon. But overall, our program is very healthy in this realm, and the pediatric results are just as good, if not better. So this is that same patient who Dr. Rodriguez put on and just decannulated 10 days later, and she's still recovering in the NICU and doing pretty well. It was exactly what we talked about. She needed a lot of support up front. After enough time went on, enough lung rest, the lungs opened up and just started getting better, got decannulated. So I'd like to spend just a few minutes talking about pulmonary embolism and the role for ECLS in this. So I've had some eye-opening data presented to me recently with it. So again, I've talked about this before with the group. We have the pulmonary embolism response team here. And important component of that right here is, when somebody's in shock, they kind of just bypass a lot of the normal runaround, and you go right to basically getting our service involved, and really the ECLS service, which at this point is the PICU. And the reason for that is that somebody who's in severe hemodynamic deterioration from PE needs to be supported, and that is probably really good therapy for pulmonary embolism. This is a review kind of talking about one institution's experience with using VA ECMO for PE patients, and they had a historical group where they just sent them right for embolectomy, and then they had another group where they just kind of put them on VA ECMO and then either did an embolectomy or just it got better on its own. And that was about half and half. About half of them went to embolectomy and others didn't. A couple in the intervention group, they just took right to surgery. If they were neurologically intact and very stable, they just took them right to surgery. So this was, and overall they had much better survival in the group that was randomized to the intervention. But importantly, I think this is even a little bit behind, because Dr. Young and I recently attended a really nice session at the STS meeting, which is our large societal meeting, and there was a panel group on ECMO and PE. And really what it seems like a lot of people are doing is if you have a massive pulmonary embolism, ECMO itself is probably good therapy for most people. Again, these are for people that are a little bit hemodynamically unstable, severely hypoxic. You just put them on, you get them stable, and then just like people that have submassive PEs, if you give them heparin in time, they're probably going to get better, right? The clot will lyse, things will perk up. That's how we manage most PEs. So it's the same thing with the massive PE. You just put them on the support that they need temporarily, and then the clot will usually go away and lyse, and that's the therapy. And they really, the panel group that we're talking to, people going to embolectomy is very rare now. And that was kind of eye-opening for me, because I've had even patients here that we've stabilized and then taken them immediately for embolectomy, because that's what we thought we needed to do. But I think that's really important in this group, because you can imagine the type of person who's having a massive PE. They're obtunded, you're worried they've had a hypoxic neurologic injury, you're not sure kind of what's going to happen to them, there might be other organs involved. So if you can just completely support them hemodynamically and from a respiratory point of view, that gives you time to sort out if they're viable or not, without adding the insult of a open cardiac surgery and things like that. Some people even infuse a little TPA through a PA catheter, things like that. But really, I think just giving it time and heparin, which is inherent in ECLS, will fix it most of the time. So that's probably a trend more and more people are moving to. And I think it's important to keep in mind for your massive PE patients that you can support them and you give them time, and it gives you an opportunity to sort out what you might do next. And then, we have good tools to help us decide when we might need an intervention. I won't dwell on it, but really, getting an echo and or getting a CT scan is very, very helpful in deciding what these patients might need. The RV to LV ratio, you can see that really easily on a 4-chamber view. The intensivists here have gotten very facile at bedside ultrasound. We rely on it pretty much every day in our unit. And you can see what the RV is doing relative to LV. The RV is supposed to be smaller than the LV. Like this picture, this is a normal heart. RV is pretty small, whereas this one, somebody with a massive PE, the RV is huge. And the same with the PE scans. Now the radiologists here on every scan are instructed to and read the RV to LV ratio. And if it's over 0.9, that at least merits some concern. So just kind of emphasize the point of PE. So now moving on to trauma. So again, contraindications for ECLS, there's none absolute, but you have to use some, you have to use some discretion with this. So relative contraindications to ECLS in general, whether you're talking about VV or VA, well, bleeding, high bleeding risk, this is a lot of the trauma population. Severe coagulopathy, again, a big deal for trauma, especially in the acute phase. Other things like a bad neurologic injury, prolonged CPR, because again, those patients don't do as well. All these other things, other organs that may be compromised. Sometimes you don't really know what's going on with the patient. But I think the bleeding thing has really been a big element of trauma. And I think we've found some ways to be better with that, and I think the data will show that as well. But in general, the circuits have gotten a little bit better. The oxygenators a little bit better. With adult patients, we can run them at higher flow rates, so the need for anticoagulation isn't as much. And plenty of people and centers have a lot of experience with running minimal anticoagulation on ECLS patients. And we do it from time to time too. If somebody's bleeding and we just don't feel like we want to heparinize them for a while, we do that. And as long as the flows are pretty high, I usually feel pretty comfortable with it, honestly. And we don't seem to have too much problems with it. Because as long as the blood is spinning around the circuit well, the chances of clot formation are relatively diminished. But now as you start to wean the flows, that changes a lot, and you really need to probably get their anticoagulation more therapeutic. But all those things have kind of helped open up the space for traumatic injury patients in attenuating that bleeding risk. And the one thing to keep in mind is even if you're not giving heparin on ECLS, there's going to be a functional coagulopathy, because as you're putting all these blood elements through the circuit, they're just not going to clot as well. So really, I was hoping to be able to present, especially for this group, some novel use of ECLS in resuscitating trauma with shock, people that are just collapsing. But I didn't really find anything that useful. I mean, there's case reports and some things like that. But basically, as well as we all know, if somebody's in shock with trauma, it's often hemorrhagic, and that's uncontrolled bleeding, and you got to control the bleeding more than anything. And putting them on circuit is probably not the best therapy. It doesn't make sense just conceptually, and people haven't really explored it that much. It's just not what people seem to be doing for the most part. There just seems to be better therapies. But where it has, and where I see it making more of an impact moving forward is in post-traumatic respiratory failure. I mean, that's really what it's about. And as is seen often, the ARDS isn't right away. It's a few days after the initial injury, especially with blunt thoracic injury. And by that point, the bleeding risk is usually calmed down quite a bit. I mean, the acute injury's over, they've had their XLAP or their intervention or whatever they needed, or time has gone on. And then when that ARDS sets in and they're hypoxic, but otherwise very viable, your bleeding risk should be a lot less. And that's where it's going to have more of a use. So again, the overall data is not great. There's no real awesome prospective randomized studies, but we can glean certain things from different things. So one thing here is that, and this was kind of a systematic review type of patient or type of paper. The bleeding rate was pretty low. So like in the early studies, it was kind of high. And again, a lot has changed with ECLS over time. But in the more modern studies, like after 1995, the severe bleeding was less than 15%. One group that I think is kind of like pushing the envelope a little bit with this is out of Germany, and this is for two groups of patients, probably included in the series, but there was one group that was actually U.S. casualties that were being airlifted to Landstuhl, and they were putting them on, this is for respiratory failure after usually blast injury. They were putting them on VV, ECLS, or PECLA, which is where it's like VV, except rather than having a pump that actually moves the blood, it's VA because the artery is the pump. So you run it through an oxygenator, but it's their own cardiac output that's driving the pump. So it's about half and half. And that hasn't really gained a lot of enthusiasm. I mean, there's been a couple studies on this, but mostly it's just pretty easy to put somebody on an actual centrifugal pump. They're so small now, like that one I showed you. But those patients did pretty well. And they also have just a bigger group of people that were, again, post-traumatic injury. This is some civilians as well, too, but also some blast, motor vehicle collision, stuff like that. And they just were just real aggressive about putting them on ECLS for respiratory failure with very good results, 80% survival. And then, again, just another sort of review. This is through the ELSO database. And again, I think the most important thing we can get out of it is the bleeding stuff, is that overall the hemorrhagic complications were pretty low, unless there was a high-risk injury. So if you had a grade 5 spleen or something, that might be somebody who is more prone to have a bleeding event. But in general, if they had going into it a smaller risk of a bleed, the ECMO itself didn't seem to cause a lot of hemorrhagic events, and there wasn't a lot of intracerebral bleeds or things like that that would sort of caution against doing it in this patient group. So I think it's kind of showing itself that the data is sort of accumulating that in the post-traumatic ARDS patients, just like that actually very first patient in 1971 in San Francisco, that this is a pretty good use of therapy. And, again, I think you can use those scoring systems to kind of help tease out who might have a potential for doing well and not doing well, and making these hard decisions when it comes time to do it. And of course, the authors here are encouraging more data on this particular subject. So kind of going into the last segment of this, cardiogenic shock. So this is kind of where I mostly live and breathe. So there's a lot of reasons to be in cardiogenic shock, but probably the most common is going to be an acute massive MI. That's probably the most common thing we see. And then there's patients that have end-stage heart failure or an acute heart failure, or an exacerbation of chronic heart failure. Acute myocarditis, and that's an important one, I think, for ECLS, because again, the reversible causes. So there's many patients that will develop a very weird, spontaneous viral cardiomyopathy or pericarditis that leads to decompensation, and that's usually a pretty reversible process. So if you can support them through it, it's an important thing. Post-cardiotomy, after cardiac surgery that maybe didn't go the way you wanted it to, or weird things happen afterwards. The postpartum group, which is a devastating group. Again, people that just kind of hits them out of nowhere, where they deliver a baby and think things are going okay and the heart just fails. And then what we're seeing probably more and more of now is temporary support during high-risk interventions. So if the cardiologists are going in and doing a 3-vessel PCI on a patient that we didn't think was good for surgery, the EF is low especially, they're probably going to think about using some sort of MCS to support the heart while they're doing all that intervention. Now, the criteria for initiating it, there's no hard criteria, but some of the important things we look at is a low cardiac index, so less than 2 liters per minute per meter squared. High filling pressures, so if the CVP or the wedge are really high, that means the ventricle is not emptying well. The 20 is probably a good number to at least think about it. People that are persistently hypotensive despite being on good inotropic therapy and otherwise being well optimized volume-wise and stuff like that. But I think it's really important is to just keep in mind end organ perfusion. That's what it's really all about, right? The organs are either getting enough blood flow or they're not. They're getting enough oxygen or they're not. So if you're seeing evidence that things aren't going in the direction you want, that's probably a good time to at least be thinking about what you might do next. You might not be ready for it yet, but okay, is this somebody who could do better with a balloon pump? Do they need ECMO or whatever it is? Just kind of get the wheels turning early, because if you're going to go down that path, it's good to have a plan. So contraindications in this group, again, no absolute, but things that we have to kind of keep in mind in the cardiogenic shock population is, where is this going? Like, what's the bailout here, right? Somebody who is 85 years old and just had 3 valves done and is in total shock and bleeding and things are, already has cirrhosis. I mean, they're probably not going anywhere with that. Probably just delaying the inevitable, maybe. But other people, again, like a viral myocarditis, might get better real fast. If they don't get better, probably going to be a transplant candidate or an LVAD candidate. So it's important to know what your bailout is and where you're going with it, what you're bridging to. But if it's an unrecoverable heart and they're not a candidate for any bailout, that might be a reason not to do something. Poor long-term prognoses, all the things that kind of make sense, cirrhosis, stuff like that. But how do we decide? Again, same thing. Well, this is that SAVE score. So again, it's not perfect, but it's kind of what we have. And they've used the ELSA registry, which is so great about this registry, right? People put in all this data. It's the only way to really make any sense of any of this stuff. Because most programs are going to be relatively small. Even the busiest ECMO program in California was less than 100 cases and dropping the last few years. So they just queried the database, look at all the different parameters, and then kind of determine a scoring system. So without going into all the fine print, again, very useful. You just kind of look at what your patient has, and it'll give you some numbers, it'll give you a survival percentage, it'll help you kind of decide, but it helps you know what also to avoid. So people with end-stage renal disease, That's a very poor prognostic thing. And we reviewed our own data here at UC Davis on that too. Our patients that were end-stage renal patients tended not to do very well. People with reversible things like myocarditis, VTVF, if the lungs are still working well, those are all positive things. So I think that's really helpful to help decide. Again, because there's a lot of emotions involved. There's probably going to be a lot of different people debating, different opinions, and be able to put some objective analysis to it can be really helpful. But what we've seen with this scoring system and all the others and experience is that if you're just doing it at the very end as just a salvage and a last ditch, that tends to not work out as well. You want to try and identify it. The sooner the better. The sooner you can get ahead of the organ hypoperfusion and the terrible acidosis and all the badness, the better they're going to do. So that's why, again, I encourage people to just kind of think about things early. And one thing that's been really revelatory for me over the last few years is this concept of venting. So, when you put somebody on VA ECMO, again, the goal is that you're drawing all the blood away from the right atrium and putting it all back somewhere on the other side of the aortic valve. So you're taking the heart and lungs out of the circulation, so to speak, and you're oxygenating all the blood and you're pushing it forward and you're resting everything in between. But even if you have great venous return, you still got to anticipate there's going to be some blood coming into the left ventricle, if from nothing else, the bronchial arteries, right? Because those directly go into the left atrium via the pulmonary veins. And so, in an adult, that's probably going to be 0.5 liter a minute of blood on averages. That's going to come into the left ventricle, even if you have a great circuit flow. So that means the LV still is going to see some blood and likely, possibly deoxygenated blood, depending on what's going on with the lungs. And if that LV is distended, that's probably not going to optimize the recovery of the ventricle. Most of the time you're doing this because the LV, at least in adults, again, pediatric population is a little bit different because they deal with really more right-sided problems. But for us, it's mostly the left side of the heart. If the LV is distended and full, the energy needs are increased. We know that. We live by that. That's what we do in the cardiac room every day. If we're doing a valve operation or whatever we're doing, when it's time to stop that heart, one of the things that's of utmost concern to us is that the LV doesn't get distended. So if they have aortic insufficiency and we cross-clamp and we're giving cardioplegia and the LV blows up like a balloon, our goal at that point of the operation is to calm the heart down. We're trying to make it cold. We're trying to make its ATP needs as minimal as possible. We're giving high potassium solution to stop it. Well, if the LV is distended, the oxygen needs of that myocardium is going to be substantially more than if it's relaxed. We know that, so we don't let that happen. We put a vent in, we drain it. So I think the same thing applies to ECLS, not in all patients, but in certain patients. So if you're really trying to optimize that LV recovery, which is usually the goal, I think a big blown up dilated left ventricle is going to be bad news for a lot of people. Now, most of the time, it's not going to be that much blood coming to the heart, and it's going to be contracting just enough that it'll keep itself empty, and it's not a problem. But sometimes it is a problem. And especially if the heart is so weak that it can never open up the aortic valve and it can never overcome the afterload pressure that the circuit is running on the other side of the aortic valve, it can potentially distend quite a bit, and then that makes things worse. Then you can see an x-ray that looks like this, where all the blood flow is backing up into lungs and they get pulmonary edema. So early on, I saw many patients that just had terrible whiteout lungs on VA ECMO, and it never quite made sense why, but this was what was going on. And then once I started to understand this concept of making sure that LV is empty, or at least empty enough, or checking chest x-rays periodically to make sure that's not occurring, that was really eye-opening for me. And I think, again, it's hard to show it, and there'd probably be some great animal study, maybe that's been done that I haven't come across, or that somebody could do to kind of help show the difference in recovering a ventricle when it's nice and decompressed versus not decompressed. But I think that's an important concept in ECLS and something I really took away from my experience doing a lot of it in Los Angeles. So we have lots of ways to vent the LV, and you can kind of do whatever makes the most sense. So again, not everybody needs this, but if you're getting whiteout lungs, the heart's not moving, it's real full-on echo, you should think about doing it. So an impella is a great way to do it, as long as there's not LV thrombus or some other reason they can't have an impella. You got that tandem heart system that I kind of showed earlier, but essentially you put the inflow cannula up through the IVC. You have to cross the atrial septum. You have to make a septostomy, so usually it's done in the cath lab. Then you draw from the left atrium. That device isn't really used very much anymore. What I will usually do, if we just want to do it quick or not sure what's happening or don't want to mess with an impella, is just make a little tiny little thoracotomy and pop a cannula right in the LV apex. And that works really well. You can do an atrial septostomy, but I don't think that's the best therapy, or just put something straight in the heart from the atrium or something else. But anyway, whatever it is, you just got to find a way to vent it out. And I think for a lot of people that can potentially make the difference for getting that heart back or not. It's even gotten to the point now where I think there's an advantage to that, but I also think a lot of patients, at least the adults, most of the time when they're not doing well, it's again, a left-sided process. And if you can support the LV well enough, things will probably be okay. This is why LVAD therapy works, like durable LVADs, like HeartMates and HeartWares. You have to select out the patients that have biventricular failure, because you're only putting an LVAD, a left-sided support. The RV has to push enough blood forward to make the LVAD work. There's no FDA-approved durable RVAD. It just doesn't exist. But thousands of LVADs go in every year, because again, most adult disease is left-sided, and the RV doesn't need as much. I mean, if you can make the LV work, usually the RV will just push just enough blood forward to keep the LVAD working. So same thing with a lot of patients that are in shock. Usually just supporting the LV is enough a lot of the time. So we've had more, for better or worse, we have more and more patients coming to us from other centers, other cardiac surgeons who something's happening, they put them on VA ECMO, and now they need help. They have no bailout. So they send them to us, and some of them, just even hearing the story, I know the first thing I'm going to do is take them to the OR and put an Impella in, because I want to decompress that LV, and then often there's several times we just take them right off ECMO then and there. And that's a really nice thing to do. And even if you can't get them off ECMO right away, you have a nice vent in. And then as you're weaning your VA ECMO off, which is, again, biventricular support, you can just transition them to LV support only. And the Impella, especially when it's put in an axillary position, is a much more sustainable situation to be in than cannulated in the groin or cannulated in the chest with VA ECMO. So kind of getting to that, we have a lot of other tools now. And this is, again, kind of where I see things going with ECLS. I think this is what we're going to see more of moving forward. So there's a lot more ECMO being done. We're learning more about it. But VA ECMO still has a lot of complications. There's still stroke problems. There's bleeding diatheses. There's vascular complications. The stroke is significant. And so I think anytime you can avoid VA ECMO for a prolonged period of time, that's probably the right thing to do. So sometimes they just need, VA ECMO is like the big gun, right? Like full-on lung, full cardiac support, good support. And that's really good for like a day, 2 days. But then if you can, I think it's worth trying to transition to something else that can last a bit longer. Because in my experience, VA ECMO for more than 6-7 days usually doesn't turn out well for a variety of reasons. And not, sometimes just the heart doesn't come back, but sometimes you just start having complications related to the ECLS itself. And then also, usually the patients are stuck in bed, either the chest is open or the groins are, involved and you can't move them. Whereas a lot of these newer therapies, you can get them up out of bed and mobilize them and do pulmonary hygiene and make sure they're awake and talk to them and figure out what's next. And maybe they need a transplant, so now we can have a conversation about it and things like that. So, again, these are sort of a lot of the tools we use now. So we have this Impella device that thing can generate 5 liters a minute of flow, which is plenty for almost anybody. We have an Impella RP, which is an RVAD that goes up to the IVC. I'm not as excited about that device in terms of support, but I think the data is slowly accumulating, but it's a reasonable thing to use. We have this really nice new RVAD. We just got that this year at UC Davis. This is a picture of a patient on it. It's basically floated just like a swan, and it comes down through the IJ, and the inflow is here in the right atrium, similar to an Avalon cannula, which most of you are probably familiar with, and the outflow is in the PA. So you're just completely bypassing the work of the right ventricle. It's really, pretty smart. And you can oxygenate it as well. So it's an RVAD and it's VV ECMO. So like on this guy, this is somebody who was sent to us on VA ECMO from somewhere else, cardiac surgery. Initially was doing well, had a cabbage, was initially doing well, then collapsed a few days later. They were sending him here in an ambulance and coded. They coded him the whole way. Put him on VA ECMO in the cath lab. Dr. Boyd was there, bailed him out. Got him on VA ECMO. They kind of sorted that out, figured things out. And then the next day, we came in and we put an Impella in via the axillary artery. You can't really see it. It's right here. Or sorry, it's over here. It's under this bandage. And then we put this thing in via the right IJ. So this guy's basically on VA ECMO, right? He's got an oxygenator. He's got an RVAD. He's got an LVAD. But he's not on ECMO. And he's walking right here. I had a video of it. He's a little shaky. But I didn't know how to black out the eyes on the video. But he ultimately did okay. I mean, it took a while. It was a slog. He was here for a couple months, but he made it out, and he's doing okay. So I think there's an advantage to that. Just getting his chest closed, getting him off. Well, he didn't have his chest open, but peripherally cannulated, groins, all these things, and then you can kind of wean it and figure out what's going on, and it gives you opportunities. This is a centromag system. This is basically, just two small centrifugal pumps, just like the ones we use on an ECMO circuit. One's going on the right side only with inflow in the RA and outflow on the PA, and then the other one on the left side of the heart, which again is a little bit more durable solution. A centromag like this, even though you have tubes sticking out of your chest, there's plenty of people now. I think USC has a pretty good experience of keeping people on this for a month, 2, 3 months while they're waiting a heart transplant. So that's just a little bit more durable setup than being on VA ECMO, and I think we're gonna see more of a blend of using these different types of devices in a positive way. It's very expensive. I mean, each of these things costs a good chunk of change, but these are people's lives, and they don't really have a lot of other great options. So that kind of summarizes it. I think, just in summary, the utilization is going way up. Outcomes are about the same, but more and more people are being helped by it all the time. And I think as we have a better idea of who exactly are the right candidates, the outcomes will slowly start moving the needle a little bit in a positive direction. You can use that RESP score and the SAVE score right now. But again, I think those scoring systems and tools are just going to get better over time as patient experience improves. And that's why the ELSO database has been so valuable. We don't know for sure with ARDS what the role is, but I think it's sort of slowly accumulating, and there's trends towards better survival with ECLS, and as the circuits have gotten better and the cannulas are getting better, and even as people are getting better with mechanical ventilation, I think that helps show that it's superior therapy. If more centers are really good at doing lung protective strategies and really good mechanical ventilation, and you still can't get them better, well, this is the way to go. And for massive PE, I think it's showing itself to be great therapy. Fortunately, that's a relatively rare event, but this is really good therapy for those that have it. And I think that triage thing is really nice because these people are hypoxic, they're in shock, all these problems, and you're not quite sure how aggressive or not aggressive to be with them. This gives you time while fully stabilizing them. And in trauma, I think it's still mostly with the post-traumatic ARDS, but it's showing itself to be really pretty good for that. And I think the burn population falls into that as well, not as much data as the trauma, but it certainly has a role. And when it comes to the bleeding risk, I think one of the points I wanted to get across is that it deserves a discussion anyway. Nobody should ever blow off somebody saying, oh, this person's not going to be a candidate for ECLS because we just took out their spleen or whatever. We should probably have that conversation because there's things we can do, less heparin, watch it close. I mean, again, if it's that or just further decompensation, it's probably worth at least talking about it. And VA ECMO ECLS is still the biggest bailout for cardiogenic shock. It's again a big gun therapy to put in there, but it has a lot of complications, and I think the more time you can minimize on it, probably the better. And I think as we use these other technologies, it'll help a lot. And then I just want to emphasize again the importance of team therapy with this. Multidisciplinary is so important with this. I mean, I know for a fact that our patients wouldn't do so well if we didn't have such great help from the nurses and from the pediatric ICU and the MICU and whatever other service the patient came from that knows them well. It's really about multidisciplinary care for these patients. The advanced heart failure team is getting more involved too, because that's really how patients do the best. And then just the goal-directed therapy. If you set goals and you can't reach them for some reason, you got to figure out why. Maybe change your goals, but it's really important to do that because that actually progresses people. And time is of the essence with this type of therapy. You can't just sit them and spin them and hope things are good in a week or two. That's pretty much it.
What a tour de force of the latest in cardiac surgery. Young comments?
Well, that was I guess on an important day-to-day basis, and you alluded to this, you have a patient who's 5 days post-op or hip replacement, and for all reason appears to have had a massive PE. He's got right heart strain on the echo, and they've started stroke support, his blood pressure is 80 systolic. What are you going to do with that patient today?
Did we present this patient last week? Someone-
I wasn't here.
Yeah.
Sorry.
Well, yeah, I mean, I think, well, if they're really going south and you really have a strong suspicion that it's PE or you're just not sure and there's otherwise viable, just early activation of an ECMO team is not a terrible idea, just in case that's the direction it goes. But, I mean, somebody like that, you probably have enough time at least to get an echo, and that'll probably help give you the info you need. Because if there's clear RV strain that wasn't there before, or, and the setup is right, I mean, the data's good, enough there that they're going to probably suspect PE and need to do something. So, I mean, in terms of the PE therapy, I think overall, IR-directed catheter therapy is really, really good therapy for most people. There is a role for systemic thrombolysis, but probably not quite as effective as the catheter-directed and maybe a little less safe. But I think that's kind of the beauty of this PERT setup, is that you can kind of get all the different providers talking to each other and kind of figuring out what's best. We know that if things go south really quick, we just got to stabilize and then sort it out. But for most of these people, a little bit of inotropes and some heparin, and then moving usually towards a catheter-directed lysis is going to be pretty efficacious.
So you call it, you activate the protein, not the blood. By the time the calls are made, blood pressure is 60.
Yeah, I think that at that point you call cardiac surgery and the PICU team simultaneously.
When you going to do what?
Probably for something like that, bedside cannulation to put them on VA ECMO. Just peripheral percutaneous cannulation and get them stabilized and then sort it out.
Dr. Youngstracker did have a death similar to that in the OR last week. Dave.
Can you comment on mechanical support for severe hypothermia refractory to conventional rewarming techniques?
Yeah. No, it's excellent therapy for that. I think where it really makes the biggest role is helping with the dysrhythmic events that occur during the warming. So, for somebody who's not responding to conventional measures, and especially if you're seeing a lot of VT and myocardial irritability, or they're just super, super cold, like super cold, then I think that's very appropriate therapy. And those patients, we've reviewed those in some detail here at our institution as well. Those patients have tended to do really well. It's usually a very short run, not a lot of issues associated with it. They just kind of keep them steady through the rewarming, and then once they're warm, they get decannulated. So I think that's a good thing to open the discussion on. We've had a couple patients we reviewed that on over the last year or so, and but where I think it really makes the biggest difference is the myocardial irritability. If they're not irritable and they're rewarming steady enough and things are okay, then you can just ride it out, with the team on alert. But I think that's where it probably makes the biggest impact.
If you're rewarming someone, do you need it to rewarm? Is that a vena arterial? Do you need a pump to do that if they're myocardial irritability?
Yeah, I think the VA is going to be the best way just for hemodynamic support. But yeah, you can warm very controlled with ECMO.
Yes.
That was a great talk, Paul. You mentioned that the ECMO utilization is increasing, specifically in the adult population, and I agree with you about the multidisciplinary team and both-oriented therapy and approach. Where do you see ECMO going in the adult setting? And in terms of that, I mean, primary management. I've had some issues with the pediatric people managing these patients, and I don't know that they're very able to do these. There's some disagreement in terms of what was the best outcome, in terms, not best outcome, but best management. And I don't think there really is anybody that's more experienced in managing ECMO patients than the cardiac surgeons, because we do ECMO every single day. And so I think that there is time, and I've mentioned it before, it really hasn't caught on for the surgery department to actually develop their own adult ECMO program.
Yeah, no. So yeah, a couple comments. Well, just like the rest of ECLS as a whole, really a lot of the early work was pediatrics, and our program here also develops sort of more out of a pediatric need, and with better data to support using it in kids. Now, and so that's where the reason why the ECLS at UC Davis is housed in PICU, and amongst the pediatricians, and Dr. Raff and Dr. Mathieu and their whole team have done an excellent job with it. But as things have morphed over time, we're seeing more and more adult patients. And I didn't, again, for time, I didn't have too many slides, but I did review the proportion of adults versus peds here over the last 10 years, and it's even now, whereas 10 years ago was substantially less on the adults. So we are seeing more and more of it. As that's occurred, we actually have been approached by those team members to kind of try and start splitting away a little bit, just also for resources. It becomes, as we're using more and more of it, it becomes harder for them to manage not only their pediatric patients, but then also the adults. So we're actually kind of in the early works now of developing a mirror team to the PICU team on the adult side that will have heavy involvement of MICU. I want to involve burn surgery, trauma surgery, cardiology, and cardiac surgery as a unit to help kind of move it forward with an adult-focused team. We'll still, for reporting purposes and CQI and a lot of practical terms, probably resources as well, we'll still have a shared thing with the PICU and the existing model, but functionally, we'll probably have two separate, probably within the next year.
Is it fair to say that most of the growth of ECMO programs around the world has been in the adult side?
Yeah, I would say proportionally. I mean, yeah, it's proportion, yes.
That's a question right there. Yeah.
That was a great talk, Paul. I just wanted to dovetail on what you're saying. I think it's pretty clear, at least in most of the places I've trained, that neonatal, pediatric, and adult ECMO are actually quite different. In terms of the diseases you treat, the outcomes are actually really different among them. Yeah. The length of the runs actually are different as well in terms of what you're willing to sort of tolerate in terms of length of runs of ECMO. And I think it's great that there's energy going towards making an adult program. That's awesome. My question for you, actually two quick questions, and one is, what's your take on non-anticoagulated ECMO trauma? And because we've had some good and bad results with that. And the literature sort of sparse, it seems.
Right.
And really sort of the second question is, what do you see about the cost of this? This is something that we talk about a lot and don't do much about, but it's one of those things. The latest technology review magazine from MIT said, had a cover of baby and said, it'll cost $2 million to save her, should you?
Right. So getting to your second point, I think that's an extremely important thing to keep in mind with this therapy. I mean, this is great to talk about, and it's exciting, and it looks cool, and pictures and stuff, but these are real people. A lot of them aren't going to survive. There's a lot of emotional and financial and resource toll that goes along with that. And as neat as it is to think about everybody getting cannulated on the streets of France, I mean, is that sustainable? Does that work? Should we be doing that? And those are really tough questions to answer. And that, poor Dr. Arabia at Cedars, he was a lot of times had to kind of be that voice of reason or sort of the devil's advocate for saying, hey, maybe we shouldn't do this because at the end of the day, somebody has to be accountable for all those things. And so I think that's a really, really important point, and it's something that people do talk about, but it's hard to put dollars on a human life. And what was the first?
About a non-anticoagulated.
Oh yeah, so the remark of not using anticoagulation especially for trauma patients. I think it's just like all things with bleeding and clotting. It's just all risk benefit. Nobody has the answer. So that's where, and because the field is still evolving so much, you just have to individualize. And if it's something that, if it's otherwise somebody who you really feel deserves that chance and there's a moderate bleeding risk, but you have ways to monitor it, yeah, maybe that's something you just go for it. You maybe get a little heparin to put them on and then not run any for a while. But it's going to be, I think it's going to take a long time to know for sure. Or probably what it's going to take is some sort of disruptive technology that takes heparin out of the equation, and then you can just run people without it. But it's just always going to be a risk benefit with that, and just individual, and that's what's so challenging about the field. Yeah. So at our institution, it's probably a little more efficient because we have 2 nurses at the bedside. At a lot of places, they have a perfusionist sitting bedside, and that can be quite. I mean, that either one, it's somebody having to sit there and being paid to do that. But we have, for us here, we have 2 nurses, and then the perfusionist will usually make rounds once or twice a day just to check on things. And then, of course, all the physician personnel. But it's 2 nurses at the bedside.
Dr. Press?
So what you're talking, so you know there's been renewed interest in the transplant world, ECMO taking organs and putting them on ECMO surgery.
Yeah.
And I had a question just about the portable machine that
Mhm.
you showed.
Mm-hmm.
Is the advantage of that to be used off-site? And has there been much experience?
Yeah.
What's the plan for using it here?
So that can be used, most of the uses of it are probably just on-site on a cart, with all the other stuff built into it. That's probably how the majority of those are used, just by the numbers. But that one is, and others, but that one especially is really easy for transport. So pretty much I think almost everybody that comes to us from some pretty small hospitals sometimes will come with that CardioHelp machine. And it's really not unusual now for even smaller community hospitals around the state to purchase 1 or 2 of those just to be able to put people on and then send them somewhere else. And I think that type of technology is what's really contributing to the overall utilization of ECLS. So it can be on a big cart with more moving parts and more monitoring and heater coolers and all these things, or it can be really skinny down to just an oxygenator and flowing blood. So you can kind of make it fit your needs. But for us, we need new circuits. Ours, the ones we have, are wearing out and expiring. So we're kind of moving into this newer device. It's a bit more expensive, but again, more and more people are using it, and it seems to work pretty well.
Why don't we conclude with Dr. Boyd as the last question?
Great talk, Tom. Your presence here at UC Davis has really enhanced not only our division and providing better care, but I think in the institution in general. So thank you very much for that. You're really taking care of this program in a big way. I have just 2 quick questions. The first one is that I'm an old guy, and when I was training, we used to ventilate people prone and jet ventilators. I don't see any of that anymore. Do people just immediately default now to ECMO? And have we gone away from aggressive, optimal, just management with that kind of patient just because we have that? That's question number 1. The second question is something that's a little bit different. When we tend to crash people on VA ECMO, we always tend to go peripherally. And I'm just wondering if there's been any problem with hypoxia in the head by doing this cannulation, and is the optimal cannulation for VA ECMO actually acts? Is there an optimal cannulation for VA ECMO?
Yeah. So Dr. Boyd brings up a really good point on this, both of them. But the second one, so peripheral cannulation is easy and typically fairly easy and fast. But you can certainly have this phenomenon where you get mixing of deoxygenated blood up in the head. And the reason for that is if the lungs aren't working too well and they're ejecting blood, if all of it's coming retrograde up through the aorta, but the heart's still pushing blood, there's going to be this area of mixing from the blood that's coming from the heart versus the blood that's coming from the ECMO circuit. So if the lungs aren't working well, there's a high potential for that deoxygenated blood that's coming across the aortic valve to go preferentially up the innominate artery into the right side of the brain and the carotid artery on the left. So it's actually essential for anybody on VA ECMO who's cannulated in the groin to at a minimum have a pulse ox on their right finger to make sure that you're not getting that mixing effect, but probably you should have a radial artery catheter so you can draw all your gases from there. Because if you just check groin gases, they're probably going to look pretty good because it's all down here. Meanwhile, the brain's hypoxic. So in that respect, peripheral cannulation certainly is inferior, plus the vascular complications not being able to ambulate them. But then on the flip side, not having the chest opened, is somewhat advantageous for bleeding and time and ease. But I don't think most people would argue that if you have cannulas centrally, that's probably the best setup in terms of support and flow and making sure the blood's going the way it needs to go. In terms of optimizing mechanical ventilation, Dr. Sabat's trying to escape. He's here. Just Dr. Boyd's comment about optimizing ventilation before going to ECLS.
I think like 10 years ago, everybody was going on the oscillator when they were failing traditional mechanical ventilation. That there was those Oscar and oscillate trials that came out in like 2011, 2012 that demonstrated no benefit to using the oscillator as a rescue role for area. So if you're at that point where you're like, I just don't think I can get any more bang for my buck with the ventilator, you just throw it on the oscillator and just see what happens. That seemed to be okay. But the other trial that was the early adopter, where they said like, we're not going to wait, we're going to put people early on the oscillator, And we're going to see if early lung protective open lung ventilation helps prevent early lung injury that leads to worsened outcomes down the road. The fibrogrowth process is severe areas. And you never get off the ventilator, right? It's week 3 and you're still super restricted. That trial showed increasing mortality. And so as a result of that trial, it stopped early. And so a lot of people, that was right around the time that the Oscar, I'm sorry,
Caesar.
Caesar, thank you. Right around the time the Caesar trial came out. So there's just a big shift as a result of people seeing oscillator as like really just a rescue mode that occasionally worked, and then suddenly seeing benefit out of ECMO. And then, so all that data coming out right around that same time resulted in kind of a shift. It's just a momentum building those results. So there was a negative trial. It was starting to push people away. Not just a negative trial, but a harm. Oh yeah, I mean that's the standard. That's the standard. So like I would essentially never put a patient on ECMO without running them first, unless like I can't even, unless like just touching them and causing the in which case you can.
Personally, I haven't seen it that much here. That's maybe
Usually like if Nikki was calling for ECMO, it's because they failed.
All right, folks. Paul, thank you very much. Great wrap.